Welcome to Breast Intentions, the podcast where we take off the bra of expectations and dive into honest, empowering conversations. We're your hosts, Nadine and Cynthia, two Canadian girls who swapped snow boots for flip-flops in the Cayman Islands. This is your space to feel seen, supported, and a little less alone. So grab a cup of coffee or a glass of champagne and get ready for your weekly handful of truth, wellness, and empowerment. Welcome back to Breast Intentions. Today, we have such an important conversation lined up. We're joined by Dr. Nevianna Bordet, a dermatologist who has spent over 15 years helping women with vulval health and midlife changes. She's worked with thousands of women who thought their symptoms were just part of getting older, but they're not. She's here to bust myths, break the silence around vulvas, and show us what every woman in midlife needs to know.
So on today's episode, we have Dr. Nevianna Bordet, all the way from England, and is now here in the Cayman Islands. Welcome to the show.
Thank you. Thank you for having me, Nadine and Cynthia.
Yes, thank you for coming. And so you're a dermatologist, but you have a specialization in genital dermatology.
That's right. So I'm a general dermatologist. I look after babies, children, adults with all kinds of skin conditions, skin cancer. I do surgery for skin cancer, rashes, acne, eczema, psoriasis, anything you can name. But about 20 years ago, I took an interest in vulval disease specifically, so female genital dermatology. And in the UK, for the last 15 years, I've worked as a consultant dermatologist, primarily looking after women with conditions or problems in the genital area.
What got you into it?
So that's an interesting question.
Yeah.
A lot of my friends say, well, why are you doing this, Nev?
Right.
And generally it's because when I was training in Cambridge as a specialist registrar, so doing your sort of training in dermatology, this is after you do med school and all of medicine. In 2003, I started my training in Cambridge, and there was an inspirational dermatologist called Jane Sterling, and she was doing research, and I was interested in doing some research, and her research was in vulval disease. So I applied for a Cancer Research UK bursary, got that, and then kind of stepped out of training for a while just to do some research. And it was just something I kind of fell into. And then the more I studied vulval conditions, going to these vulval clinics alongside Jane and other gynecologists and dermatologists, the more I realized that that's something I really enjoy doing. I really love changing women's lives and talking about things that are difficult to speak about.
That's what I was just going to say too. And I think the word vulva is not really a word that you hear a lot of women say, and more so just because it's one of those topics that people don't really want to talk about. But why do you think that women don't want to talk about it?
So I think there's a taboo for genital conditions or talking about genitalia in general. And it's always struck me as interesting that how we talk about a penis, but we often don't say the word vulva, and we don't actually teach our children from a young age to feel comfortable to talk about their genitals. Certainly with little girls, and people will use terms like private area. The one I hate is front bottom. I mean, what's that all about?
Never heard that.
And all kinds
Or
of
childhood, like I think when I was young, we used to call it a cookie.
A cookie, yeah. I have heard all kinds of names.
Like my friend and her family did too.
Oh, that's so funny.
That's what it was called.
But there isn't a standard name. Unlike for penis, universally we say willy, but for female genitalia, there's all kinds of names. And people often talk about vagina, but strictly speaking, that's not right.
Yeah, because that would be what we would have called it as we got older, right?
Yeah.
My vagina, not my vulva.
So then what's the difference then?
So the difference is that the vulva is the external part of our genitalia. So we're talking about the labia majora. These are the sort of the big lips, often where hair comes in puberty. And the little lips are the labia minora, and the opening that is going into the vagina, so what we call the introitus in medicine. So that is your vulva, the external genitalia, whereas the big tube that goes up to your uterus or your womb, that is strictly speaking your vagina. And I think one of the reasons we don't talk about vulva is if you think back to education, and when you're at school and you have sex education, it's primarily around reproduction and about sexual intercourse. And so then we talk about vaginas, but we don't talk about the vulva.
Okay. And I won't even tell you, like, so the way that we had met was because someone had actually gone to see you, more so about certain areas like on her fingers and her feet that were like really, really dry. And she's of menopause age. And you had like flat out asked her how her vulva was. she was like, fine.
Right. Yeah. So a lot of doctors don't feel comfortable about talking about genitalia, and that's really sad. And we don't ask patients whether they've got these problems, and often they won't volunteer them. There's cultural stigmas, there's beliefs that things could be normal. And certainly when I started out in vulval disease, I felt really uncomfortable asking people, how is your vulva? Do you have pain with intercourse? Do you have a problem? And now I have spent over 15 years leading this clinics alongside gynecologists. I feel very comfortable. It's like talking about your elbow. And this is what I think that we should start from an early age, getting our children used to feeling comfortable about talking about their genitalia and saying, look, you have a vulva here. It's like your elbow. It's another part of your body. And we need to talk about it if it doesn't feel right, if it's itchy, if it's painful, if it's giving you any symptoms, if you're worried about it in any way, then there is somebody that can help you. Don't suffer in silence. And this is why when you said, do you want to come on the podcast? I was like, hey ho, yes, please. I so wanted to spread the word because I only came to Cayman in January. And one of the reasons I came here is because I was headhunted. And the clinic I was headhunted was for Integra. And Integra is primarily women and children. We have gynecologists and pediatricians. And I thought, what a great fit. I can come and I can spread the word. I ask these questions, the more I realize there's such an unmet need, not just in Cayman, but I think throughout the world, that we just need to break down those stigmas in a way that before period adverts for sanitary wear and tampons were out, we didn't talk about periods. Saying the word period was not normal. Now we can talk about our menstrual cycles.
Okay.
Let's get that conversation going on vulvas.
Right. Yeah. Now, if we were to go more towards like the perimenopause and the menopause side, what actually happens to the vulva at that time?
So good question. Can I first just define the perimenopause and menopause?
Sure.
So as a woman, you can enter the perimenopause or menopause as a different age to your friends and peers. It is largely determined by genetics. So you can ask your mum, when was her menopause? By menopause, we mean when did your period stop and you had no period for 12 months. However, estrogen can decline a good few years before your period stop. And this is where we don't realize that it can affect your body with declining estrogen levels, and hence this perimenopause periods where the hormones fluctuate up and down can have a lot of symptoms, primarily on the genitalia, because that's a very estrogen receptor rich area. So that's one of the areas that really starts to suffer first. And then systemically, all the other symptoms that we associate with perimenopause and menopause. But that perimenopause can last years, and it can be as early as in your 30s. I mean, you might be very unlucky and have a premature menopause, and that's usually an autoimmune genetic condition, so quite rare. But most women's estrogen declines at 35. And then it's downhill from 40, a much significant decline, and then between 45 and 55 to almost non-existent estrogen levels.
Okay. So the main thing that happens from the vulva perspective is because the estrogen starts to lower,
that's right,
everything starts to change or get drier, or?
That's right. So yes, I didn't answer your question. I'm sorry about
That's
that.
okay.
So how does it actually affect the vulva? So the vulva has estrogen receptors, very rich in estrogen receptors. When those estrogen levels are low or non-existent, the vulval tissues thin and dry out. So from a kind of spongy, lubricated, full of blood supply to much more what we call atrophic in medicine. So atrophy is a horrible medical term. It means dying. So a sort of a dying vagina and vulva. It's a horrible term. We'll come on to that in a bit. But basically the tissues thin out and become much drier. So the first symptoms that you might experience as a woman with lower estrogen level is you might feel that you're a little bit more dry down there. You might be a bit irritated. You might have some burning or stinging or itching. You might find intercourse suddenly becomes more uncomfortable because things are a bit drier. But there's a lot of other symptoms that are in that area that come along with this. And this is why the term now, instead of atrophic vaginitis, atrophy meaning death, vagina, itis, inflammation, atrophic vaginitis, horrible, death, dying vagina. So we have moved away to a new term called genitourinary syndrome of the menopause. It's a mouthful. So GSM for short. I hate abbreviations. If you Google GSM, it will come up with some global whatever, I don't know. So I don't like the abbreviation, but it's actually a better descriptive term to have a genitourinary syndrome of the menopause, because it doesn't just affect your vagina. It affects your whole genitourinary tract.
Is that where a lot of UTIs happen more often?
Exactly.
Okay.
So what happens is, as your vagina dries out, the microbiome changes, because we need that estrogen to have glycogen stores, and the glycogen stores are important to keep the lactobacilli. So these are the good friendly microbiome bacteria. And when the lactobacilli are there, they keep the pH, which is the acidity of the vulval and vaginal tissues, low. And when the acidity is low, it prevents infection. Now, if you suddenly have no estrogen, you change that microbiome. The microbiome actually becomes more diverse, which is a bad thing in the vagina, unlike in your gut. And suddenly the bacteria can track up and cause increased urinary tract infections, or UTIs, as we call them in medicine.
Okay.
The other symptoms affected are the bladder. And the bladder can become more irritable because at the opening of the bladder, the urethra, we still have estrogen receptors. And so when there is lack of estrogen, you might find that you're needing to go more for a wee. And you go for a wee, but then 5-10 minutes later, you need to go for another wee. Or you're getting up in the night, sometimes 2-3 times, a bit like the men with prostates, get up in the night, and you go more. Or you go and then you find you might dribble a little bit. You might find you have more urgency. So when you need to go, you need to go now. Or you might even leak a little bit because you're not able to hold it in. So all of these signs can be a sign that you're lacking estrogen around those tissues. And quite often when we replace estrogen levels around the opening of the urethra going into your bladder, a lot of those symptoms will improve or even go away.
So it's not irreversible. Like, it's not like once it's gone, it's gone.
Yeah. So usually we can, with estrogen topically used in the vagina, improve the urinary symptoms. Also, the tissues around that area. So a lot of women in midlife will have carried a baby in pregnancy. And we know that strain on the pelvic floor muscles, that it weakens them. And it's actually the carrying of the baby that weakens the pelvic floor muscles, not so much the delivery. Having a cesarean section is not going to save you from this because it's a heavy load. And you're carrying around, and gravity takes its toll. And so you can think of the pelvic floor as a bit like a net that holds everything up and in. And as we carry that pregnancy, the net kind of weakens and weakens. And obviously with each subsequent pregnancy, that can have more of a detrimental effect. However, I'm told it's by the gynecologist is the first baby that does the damage. Anyway, so we can blame our firstborn. And then what women find is that they can leak a little bit of urine if they cough or sneeze, or if they suddenly have to run for the bus, or trampolines tend to be a no-go.
Yes,
And that is incredibly common. But unless we ask a woman, do you leak when you cough or sneeze, or do you have to wear a pad to protect from leakage, they won't volunteer this information. They feel incredibly embarrassed, like that this isn't normal. So often it doesn't get spoken about. But if I ask women in my clinics, do you leak? I can guarantee you most women who have had children later on in life will have that problem.
Yeah.
And we talk about pelvic floor exercises. They can really help. We have pelvic floor physiotherapists that we use and are referred to help with strengthening those muscles. But also what women don't realize is estrogen plays a really big role. And muscular tissue also has, skeletal muscle has estrogen receptors. And we often lose muscle as we get older as well.
Right.
And certainly all of these things are intertwined.
Yeah.
So then do you have to make sure that estrogen is put on those areas, or can you like take estrogen in a different way and it still helps those areas?
Really good question.
Yeah.
So estrogen, it comes in all kinds of forms. The way I explain to patients is I separate it with systemic symptoms and localized vulvovaginal symptoms. So let's break that down.
Oh, okay.
Okay, systemic symptoms. These are your hot flushes, your anxiety, your brain fog, lethargy, all those things that go around that you associate with a menopausal woman. And again, they can be minor in the perimenopause and often build as we lack estrogen. Systemic symptoms need systemic estrogen. So that means either an oral tablet or a patch where it's a higher dose, or cream, gel, estrogen, rubbed into the skin at higher dose that enters straight into the bloodstream. That's higher dose estrogen, and we can talk about that. However, if you have localized symptoms, so I'm talking vaginal dryness, pain on intercourse, urinary symptoms, leakage, urgency, frequency, getting up in the night, all those things I spoke about, then localized estrogen is important. And in fact, actually, having the systemic estrogen, I find, doesn't help. You still need localized estrogen to those tissues. And that can be delivered either with a vaginal pessary or with a vaginal cream, which tends to be a bit messy. So I tend to prefer the pessary in terms of prescribing myself.
A pill?
So it's a little pill, comes with an applicator.
Oh, I see.
And the way it's used is usually you put it in every night for 2 weeks and then just twice a week as maintenance. But you kind of commit to doing it forever, because when you stop a few months later, you get back to square one because that estrogen isn't coming back.
Then I'm going a bit off track, but so what do you do for people that have like history of cervical cancer or anything like that?
So there is a lot of worry with estrogens, and most of the data is on systemic estrogen. So we're talking, oral HRT, hormone replacement therapy, or patch or gel, which is going straight into the bloodstream at high doses. Even so, a lot of that data is flawed because the studies were done. If you look back at the studies, they're starting to be discredited. And so we're uncertain really if those risks were over-exaggerated or not. Like I said, I'm not a gynecologist, so I'm not best placed to talk about the risks of systemic estrogen. But we do warn women that there is possibly an increased risk of breast cancer, minimal, but with systemic estrogen, or of clotting, such as leg clots, DVT, deep vein thrombosis, or lung clots, pulmonary embolism, or PE. Now, that risk is not there with topical estrogen in the vagina.
Oh, okay.
And this is what people don't realize. It is incredibly safe. Using a vaginal pessary or cream to improve your vaginal dryness or urinary symptoms or reduce your risk of urinary tract infections, those topically delivered estrogens are such low dose that they are practically indetectable in your bloodstream. In fact, if we have a woman with breast cancer, we would always ask the oncologists and write to the breast surgeon and say, look, this woman has got terrible problems because of dryness. Can we use some vaginal estrogen? And more often than not, they will say yes, because the benefits outweigh the risks. There is no studies that show that using vaginal estrogen increases your risk of breast cancer. Zero. And in fact, it's been used in patients on tamoxifen therapy. So as you know, if you've had a breast cancer that is estrogen sensitive, often women will get put on these medication like tamoxifen to suppress estrogen. That effectively renders them menopausal. And they can suddenly present with horrific vaginal dryness. Yeah. So we need to be asking every woman who comes in and tells me they've had a breast cancer, I ask them, what's your vagina like? Really? And sometimes they come, but I've come for my eczema, I've come for my wart. Right. Yeah. But I feel it's my duty because so many people don't talk about these things. And we just need to spread that awareness. And yes, I would never start a woman with breast cancer on estrogen without checking with her surgeon. But like I say, if the problem isn't improving with topical measures, which we would try first, then we would always write off to the breast surgeon.
Okay. Yeah. Now, some of the words, some of the like medical language around this, and I don't even know if I could pronounce it properly. Vulval eczema. I don't even know how to pronounce the other ones.
Vulvodynia.
And Lichen sclerosis.
Okay, so vulval eczema. Like any eczema,
right?
Lichen sclerosis,
lichen,
yeah, and Vulvodynia. So these are three different diagnoses. We see a lot of this in my vulval clinics. Would you like me to explain?
Yeah, could you explain all of them?
So these are the common things I see. Vulval eczema is like any other eczema. So the vulva is a very sensitive organ. The skin there needs to be looked after gently. But unfortunately, we use all kinds of horrible products down there. We use soaps and shower gels with fragrance and with preservatives. And there is a big industry trying to sell you all this washes for your vagina. And actually, your vulva, look, I used the wrong term. But that's what they say, wash your vagina and this stuff. And actually, we shouldn't be washing any of our genitalia with this stuff. We need to use a gentle skincare. And if we don't, then we can develop discomfort or dermatitis, derm meaning skin, itis meaning inflammation. Sometimes we use eczema and dermatitis interchangeably in medicine. They mean the same thing. And so a vulval eczema can develop from inappropriate skincare. It can develop because you have eczema elsewhere. So perhaps you've got atopic dermatitis, so childhood eczema, you grow out of it, and then maybe later on in life, it comes back, but just to your vulva. So we see that quite often. It doesn't have to be elsewhere. And often presenting with itching, discomfort, or sometimes with infections. So with recurrent thrush or recurrent bacterial vaginosis or BV. Why? Because we've imbalanced that delicate area, that delicate microbiome. So I always say good vulval care, and you can have a look at the British Association of Dermatologists. There's bad.org website. There is a leaflet there on vulval care or care of the vulval skin. Essentially, we should be washing our vulva with something very kind, like a soap substitute. And these are creams that are designed for washing in patients with dry skin conditions like eczema elsewhere.
Is there a brand?
Am I allowed to say some brands?
Yeah, of
fantastic.
Course.
Okay.
Yeah.
So I have no shares in any company, just to say that. One of my favorites is something called hydromol ointment. Remember, I practice mainly in the UK where it's cold in the winter. And sometimes these ointments will go really hard if left in a cold bathroom. I find hydromol ointment doesn't. So this is an ointment that can be used as a moisturizer. So a bit like we moisturize our skin, you can moisturize the vulval skin as well. You can keep the little hydromol pot on the back of the loo, and after you've had a wee and wiped, you just dip a finger, put it all around the vulva at the opening so that everything's slippy, slidey, isn't dry, and also wash with it. So you can put it on. It's a bit greasy, but you jump in the shower, rinse it out. It will leave your vulval tissues a bit more slimy, but that's a good feeling. It's not a sort of kind of the stripped oil feeling. That dry feeling we associate with clean is actually the stripped oil feeling, which we shouldn't be doing for our vulvas. So hydromol, other makes are Epiderm ointment, Cetraben ointment. You get the idea. Anything that ends in ointment, usually in the eczema section. There's various brands that I also like. There's a brand called Yes, and they do really good vaginal lubricants for intercourse. They also do a vaginal moisturizer called Yes VM. And the lubricants they do is an oil-based, Yes OB, oil-based, or if you're using condoms, obviously you can't use oil-based lubricants, so you then go for a water-based. And I would say no woman in the menopause should be having sex without a lubricant, because naturally you are dry. Even with some estrogen replacement, it's always good practice to use a lubricant. I would always advise something like Yes oil-based, because often we're not using condoms in the menopause. And it's really important, because any kind of friction can aggravate those tissues.
Is that also the lichen sclerosis?
No, that's completely different.
Is that like rips or tears?
So rips or tears can present due to any inflammation. And lichen sclerosis can be one of those causes, but also vulval eczema will do that. Sometimes some infections can also cause rips and tears. But in general, Lichen sclerosis is a very specific autoimmune condition. It occurs usually either before puberty, so in young girls, or in the menopause or perimenopause time. We do see it sometimes in menstruating women, but it's less often. So it's something about the lack of estrogen that possibly kicks it off. We don't know, but we do know it's an autoimmune condition, can be linked to other autoimmune conditions, specifically thyroid problems. So if you've got a thyroid problem and perhaps you've got some itching down there, then perhaps you should see somebody to just check it's not lichen sclerosis. And it's a condition that is unfortunately linked to vulval cancer, and this is why it's really important to know about it. It is a low risk, somewhere in the region of sort of 3 to 5%, we think. And we think that risk is more if the condition is uncontrolled. But once we drive it into remission with treatment, we think that risk is next to zero. And that's why it's important, if you do have any itching or pain or anything that is concerning, to see somebody, get examined. Very rarely, lichen sclerosis can cause scarring in the vulval area, and it can actually lead the vulva to close off, to a kind of stick together and it close up gradually. And so then suddenly sex becomes impossible. And sometimes urination can become impossible if it completely closes over. That is very rare, but it can happen. So it is important to get those checkups regularly, just to make sure that there's no scarring if you have that condition.
Oh, wow. And then the other one?
Vulvodynia. Yeah. So sadly, this is a common condition that can often piggyback on other things. So vulvodynia is a pain syndrome. The way I explain it to patients is, actually, I'm going to use an analogy here because this is the way, I'm a visual learner, so I think it kind of helps explain it. So the analogy I use for vulvodynia is that we all know of shingles, right? So shingles is essentially, you have chickenpox when you're little, the chickenpox virus clears, but the herpes virus stays sleeping in the dorsal root ganglia. These are the little kind of areas in your spinal column. And then at some stage when you get older, usually if you're a bit run down with something else, it will reactivate. The herpes will track down that nerve, and then you'll present with a very painful blistery rash that is just over the area where that nerve kind of innervates that bit of skin. And when you look, you've got a horrible blistery painful rash. But then the rash will disappear and there'll be nothing to see, but the skin will stay incredibly painful. You can't even touch it. And that can last for months or years. Now, the same thing can happen to the vulva, but without the herpes. Sometimes there's herpes that sets it off. Sometimes it's thrush. Sometimes it's nothing. And we don't quite know why women develop vulvodynia. And I've got young girls in their sort of puberty, teenage years with vulvodynia, but more frequently older women that develop it as well. And sometimes it's because they've had vulval eczema, or they've had genital urinary syndrome of the menopause, or atrophic vaginitis, or they've had an infection, or something has kicked it off. And other times they don't know, but they are just in pain. And there's two types of vulvodynia. One is provoked, the other one is unprovoked. So the provoked one I think is more common. That's the one that you touch the vulva and it's painful, but you look with a mirror and it looks completely normal. So quite often these women get told, it's in your head. There's nothing wrong with you. They go and they're examined by other physicians. They say, no, there's nothing wrong with you. Or they get treated for thrush and their symptoms don't improve. But essentially it's pain, usually pain on touch, pain on intercourse, pain on inserting tampons, unable to ride a bike or wear trousers, unable to sit. And sometimes the unprovoked pain is just pain all the time.
Oh, wow.
So yeah, it's sad. And unfortunately, when I see patients, they've usually been to other people. They've been to their GP. Sometimes they've been to a gynecologist or a dermatologist. But unless you subspecialize in vulval conditions, you might not pick up that there's 2 or 3 things going on. Often I'll see a woman in clinic and she'll have, I don't know, a bit of vulval eczema and some thrush on top of that, and maybe even some vulvodynia. Or she'll come later on in life and she will have lichen sclerosis, but also some incontinence issues, an irritant dermatitis due to urinary leakage or wearing pads, or she'll have vulvodynia as a consequence of having had lichen sclerosis or an infection. So quite often I might diagnose 2 or 3 conditions in that one appointment.
Right. Yeah.
And unless you address all of them, their symptoms don't go away. So actually they're just going around the houses seeing different gynecologists, different dermatologists, different GPs, and just feeling like actually nobody can. And the number of times people come and say, I've tried everything, doctor, or nobody can help me, or why haven't I come to you before? And it's because we don't talk about these things, and we just need to shout a bit louder.
Right.
That this is normal. It is normal to develop things in your vulva like it is anywhere else on your body. And if you have a symptom, don't be shy. Just come and see us. It's like looking at your elbow. I always say to women that, I'm going to look down here, but I'm not going to be embarrassed. So please don't be embarrassed.
So now for people who are like in the US or in Canada, if they know that they are struggling with some of these symptoms, and maybe they're not getting the right answers from their gynecologist, who do they look up? Like, because I'm sure that they probably can't go to any dermatologist because that dermatologist might not be well versed in this. Like, so what do they look up?
That's right. So we all subspecialize, and I have dermatology colleagues who subspecialize in surgery, for example. Even though we all do surgery, if there's something a bit more complicated, I would refer to that colleague. Similarly, there are vulval dermatologists. So in the UK, there is the Vulval Society that you can look up, the sort of where the vulval clinics are. You can Google your local vulval clinic. There would be in various hospitals, and there are joint clinics, multidisciplinary clinics with a gynecologist and dermatologist who subspecialize in vulval conditions. I've not practiced in the US, but I'm sure there is something similar, somebody who's a vulval dermatologist or a vulval gynecologist, where they have subspecialized and developed that interest. And like I say, most of the time is through seeing a lot of these women and presenting and then learning as we go along. We learn from each other. I've learned a lot about hormone replacement therapy and gynecology because we do those clinics together, and I have done for years. And at Integra, I have two gynecology colleagues I work very closely with, Dr. Laura and Dr. Madhavi, and we refer to each other. So sometimes I need them to have a look more internally if there's like deep pain or some other issue that might be contributing. And sometimes they refer to me as well. So it's important to work closely, similarly with pediatrics.
But if, say, somebody's not comfortable using hormones or using estrogen cream, what are some other simple ways that we can, I mean, we talked about lubricant.
Sure.
So is there other things that would help?
From my point of view, I think good vulval care, everybody should be practicing, but especially if you've got some symptoms. A good lubricant every day will go a long way to giving you some comfort from that dryness. Like I said, lubrication for intercourse, very important. Washing with the right product and not overwashing. So once a day is more than enough.
Right.
And washing with a soap substitute, not washing with something that has fragrance, and basically if it smells nice, put it back on the shelf because it's fragranced. Not using wet wipes. I mean, they are the devil. Even the ones that say they're pure and hypoallergenic, often they'll have fragrance. Read the ingredient list. They deposit all these chemicals onto your vulval tissues and you can become allergic. We often do see contact allergic dermatitis from people using wet toilet paper. Don't use fragrance paper, use normal toilet paper, ideally white, not coloured. Again, you could react to any of these things. So if you want to avoid estrogen, then I would just make sure you have a good vulval care.
You have a lot of women who come and say, they've been to many doctors, they can't get help, or, well, I wish I found you sooner. What are the most important things women in their 40s and 50s should know so they don't suffer in silence?
Okay, so I think if you've got any symptom at all, go and get it checked out. First of all, don't be embarrassed about it. When you come and see us, we're used to seeing your genital skin. We're not embarrassed. We want you to come and see a doctor if you have any symptom. It's not normal to have pain. It's not normal to be dry. These feelings, these symptoms that you're having, there is a reason for them. Let us work out what the reason is, and then we can fix it. So for me, I think we just need to talk more about our vulvas. Talk to your friends, talk to your family. Ask your mum when was her menopause. Then you might have a good idea of roughly when yours may be. If you're not having regular periods, come and see a gynecologist or, talk to your GP about it. Why are you not having regular periods? That can get investigated. A common misconception is that we can do a blood test to check on your estrogen levels. We can, but it's not reliable. Why? Because estrogen fluctuates. And the test we do when to see if you are in the menopause when you've not had a period is something called the LH and FSH. So this is luteinizing hormone and follicle stimulating hormone. These two hormones get made in our brain to stimulate the ovary. So when the ovary isn't producing estrogen, or if you have no ovaries, if they've been removed, then what happens is the LH and FSH increase because it's a negative feedback loop. So they go up, and then if the estrogen is made, then they go down again. So they will naturally fluctuate in menstrual cycles. But in the menopause, when there's no estrogen, they'll increase and increase and increase and increase, and they go to really high levels. So yes, we can do a blood test, and if your LH and FSH is really sky high, then there's a good chance, not guaranteed, I have seen people get pregnant, so it's still not guaranteed.
Right.
But pretty much you can say, look, you're in the menopause. Now, unfortunately, if you're in the perimenopause, even if you're skipping periods, those levels wouldn't have risen to those levels. So we can't do a blood test. We go on your symptoms. If you've got systemic symptoms, so again, this is your hot flushes or flashes, your sweats in the night, your anxiety, your brain fog, forgetfulness. Again, brain fog, the brain has estrogen receptors. So we get forgetful. You know, where did I put my keys? Did I remember to pick up the kids after school? So there's a lot of symptoms that can add into this. And people get really anxious or depressed and they think it's depression. Actually, could be the menopause, maybe it isn't. But if you get the systemic symptoms, then think about systemic estrogen therapy, HRT. So go and see a gynecologist. They are best placed to prescribe that for you, not me. If you've got localized symptoms down below in your vulva, itching, pain, urinary problems contributing to anything like that, come and see me.
Sounds good. If you could clear up one big myth about vulvas and menopause that holds women back, what would it be?
I suppose somehow that it's something shameful.
Yeah.
I really dislike the fact that men are so proud of their penises. And they can say the word penis and willy and it's great. And we are so ashamed of the way we are, the way we look. We get told that our flaps are too big or too little. I just hate all that stigma.
What about this whole thing about people getting the surgeries?
Yeah.
Isn't that terrible? So there is a book called The Labial Library that we often have in our vulval clinic. There's also an artist who did The Great Wall of Vagina. If you want to look that up, he did like plaster casts of women's vaginas and made a massive wall of it. Yeah. If you Google those, you'll see. In the UK, there is a TV program that is called Naked Attraction.
I saw it. I stumbled upon it once. And I was like, oh my God.
Yeah.
Have you heard of this?
No.
By no means am I saying you should watch it. And certainly it's after 11 o'clock after the watershed period.
And it's on
shocking.
normal TV
It's
over
a
there.
normal TV.
Oh.
So it's a dating show, but everyone, it's like a door kind of thing that's covered. And the door starts, I think, from the feet up. And the person's fully naked. And you are judging.
If you want to date this person?
Yes.
Really?
Yes. It's a shocking show, but it is getting people's genitalia out there.
Right.
And, I'm not condoning the show in any way, but I think the more we talk about what normal is, and for a woman, a bit like in a man, there is a variation of normal.
Yes.
So some women have bigger labia majora, some women have smaller labia majora, bigger labia minora. Some people have more hair, less hair, different color hair. It can be normal.
Yeah.
If you're not sure, please come. We'll check for you. But it doesn't mean you need to have surgery. We don't all need to look the same. One of my bugbears, I suppose, is that young people get all their hair shaved off down there. So if I examine a woman under the age of 30, I can pretty much guarantee she will have not one single pubic hair when I examine her.
Yeah.
Why? Because it's a fashion. Do we know where that fashion stems from?
I do. Starts with a P.
Sorry?
Starts with a P.
The porn
Ends
industry.
with an N.
Oh.
Yeah, the porn industry. Why? Because if you shave all the hair, you get a better view of it.
Oh.
And it is disgraceful that the porn industry has set that standard for our young girls. And there is an expectation that if you grow your hair there, it's bad. Now, one thing I would say is I see a lot of nickel allergy as part of my general dermatology. People who present with a reaction to costume jewelry, maybe a rash around the neck from a cheap necklace, or from a rash or redness around their ears from cheap jewelry. What they don't realize is that is from the nickel. Nickel is a common alloy used in a lot of kind of jewelry and sometimes in cosmetics as well, in like shiny makeup, etc. But generally in jewelry. 1 in 10 people are nickel allergic. What is in razors?
Yeah, I was just going to
Nickel.
say. Yeah.
Okay, so actually 1 in 10 people can develop a shaving rash from removing that hair down there. There is a reason we have that hair. That hair's there to cushion the skin. And if you're riding a bike or walking or running and there's no cushioning, sometimes you can get a bit more friction, a little bit more discomfort. I think it's a fashion. Maybe it will go, but I hate where it started. And when patients come and see me with vulval eczema, one of the things I say is please don't shave the vulval skin because it's probably aggravating it. It's probably making it worse.
Right.
So that's cultural
Or
beliefs.
waxing, I guess, too.
Yeah, so waxing can be quite traumatic,
Yeah.
removing, but at least you're not getting into the nickel, but can be quite traumatic in terms of ripping the hair.
skin and
the
ripping the
things we
skin
do, this is very delicate skin. Treat it gently, be good to your vulva.
Yes.
So Cynthia, the other thing you asked me is what other things women can do if they don't want to use vaginal estrogen. And one of the things I forgot to say is massage. And again, here people don't like talking about it because there's this taboo about touching.
Yeah,
But massage stimulates the vulval tissues to have an increased blood supply, to be more lubricated. And so it's really important if you are suffering from vulvodynia, this pain syndrome, that you massage the tissues so that they can get used to what normal touch and feel and feeling and rather than pain.
Yeah.
Also, if you have dryness, it's important to massage because that lets you reconnect again with your vulva and fall in love again with your vulva, which you might have fallen out of love with if it's been hurting you and causing you problems. So massage using a lubricant or using an ointment is a really good idea. Just don't use anything fragrance, don't use any oils that are smelly. I would stick for things like hydromal ointments, Etroben ointment, Epiderm ointment, anything quite bland designed for eczema or dry skin.
So massage, and are you pro vibrator?
Definitely. So in our vulval clinic, we have vaginal dilators. These are, if you like, I don't know if you know Russian dolls, but you know Russian dolls, how you have little dolls inside big dolls. We have the same, but they're willies. Okay, so we have a big plastic willy and a little plastic willy and a small. There's about 4 or 5 sizes in vaginal dilators. But they are made of plastic, usually quite stiff. You can get some silicone ones nowadays, I think, but quite hard to get. We use dilators for women for 2 reasons. One, if they have had a scarring process. So we talked about Lichen sclerosis, this autoimmune condition. So if there's any kind of fibrosis, which is scarring, and the vaginal opening has become tighter and smaller, then we would start with a small size and ask the woman to coat it in a lubricant and then to gently stretch the tissues and then work up the sizes gently to stretch those tissues. Sometimes we will do it with a strong steroid cream, which is the treatment we use for lichen sclerosis. And so we would ask them to coat those vibrators and help to deliver the cream that way. Or to use a vibrator, you don't have to turn it on, but to use it to kind of open up the opening and make it more flexible. The second reason I ask women to use dilators or vibrators is to get back used to the feeling of having something there. So if you've had a vulval condition, especially if it's caused pain, it's completely normal to clamp down. Yeah. So the minute you try and have sex, your body, even if you try and relax, decides, nope, that's not coming anywhere near me. And the muscles can involuntarily contract, a condition we call vaginismus. And that is common, again, as an add-on to any kind of vulval condition because our body doesn't want pain. Who wants pain?
Yeah.
And you often see women coming and saying, my relationship broke down, my husband left me, I can't have a normal partner, they're scared to go into another relationship. It is so sad and so preventable. So every time I have somebody in my clinic where they've had a condition, I talk to them about vibrators. It's not going down very well in Cayman because we're quite a conservative society here. But certainly using a vibrator or dilator just for the feeling of stretch and normality and relaxation. When there's another person there, you have to think about them and their feelings. When it's you on your own, this is your homework. I often say to my patients, I'm going to give you some homework. You need to find yourself a vibrator, a dilator, and then just in your own privacy, do some massage initially, and then just, try to get used to the feeling of something there.
Yeah.
And we use pelvic floor physiotherapists a lot. I refer quite a lot to a good women's physio will really help us with this as well. But first you have to treat whatever caused the pain in the first place.
Yeah.
And if it's vulvodynia, if it's a pain syndrome, I would often use oral medication to desensitize those nerves. And it's a slow process, but it works. And I pride myself, there is no vulva I haven't fixed. It can take time, but you can help every woman. Certainly to a big degree, I think.
Yeah, wow. For a woman listening who feels embarrassed or scared to ask for help, what would you say to encourage her to take the next step?
I think question why. Why are you embarrassed? Has something happened? I'll often have long consultations with my patients and delve really deep back into their history. Has anything happened, any kind of perhaps even sexual abuse or something inappropriate? Perhaps something little, is somebody saying something in your childhood or growing up, or a peer or a boyfriend or a husband or a partner who has said something not meaning it to be derogatory or hurtful, but has said something that has made you think you're not normal, or this is why you've got the symptom. If it's not embarrassment, I hope I've tried to get people not to be embarrassed about it, because certainly we're not as professionals. But if it's not embarrassment, sort of question, what is it? And again, sometimes I would work with psychiatrists or hypnotherapists. I love cognitive behavioral therapy. So this is a technique where you go quite deep into your beliefs. And perhaps those beliefs were right at that time when you were a child or growing up as a teenager to prevent you having promiscuous sex or whatever those beliefs were. But perhaps, those beliefs aren't serving you right now. And we need to sort of change the way you think about sex or about your genitalia. And like I say, when people come and they're so obsessed that they look wrong down there, but to me they look absolutely fine, and it's just a cosmetic thing. Right. I always try and talk them out of surgery, because often surgery can actually lead to its problems, because you have to heal. There'll be scarring, and then you end up with a vulval problem, which you never had in the first place. Right.
That's right. And I think knowing, like you said, you haven't met a vulva that you didn't help, that would bring some, I guess, relief or some hope, so that might encourage people to seek help.
Yeah, and sometimes it's just a worry that you have that this isn't right.
Yeah.
It could be a lump or a bump. And, when you have a lump, you think it's cancer, and it may be.
Yeah.
So go and get checked out. But most of the time, it's something that we can reassure you that it's, I don't know, just a blocked pore or something called an angiokeratoma, which is a little lesion that comes on the vulval skin with age. And our vulvas age like everything else. And actually they do change. And this is the thing. Our bodies change as we age, and we need to listen to them and pay attention. Whether it's your skin getting drier and you have to change your facial beauty products, or whether it's your vulva giving you a symptom or a spot, or if something's changing and you're not sure, go and check it out. It could be normal. We do lose our plumpness down below, so the labia majora can sometimes become a bit less plump, and that can be completely normal as part of aging, like everything kind of. It becomes saggy and gravity takes its toll, but and sometimes perhaps a little bit of urine leakage is normal, but it doesn't mean we can't improve it, and sometimes even stop it altogether. It doesn't mean it needs surgery. For urinary incontinence, for early stress incontinence, pelvic floor physiotherapy, and if you're in the menopause or perimenopause, vaginal estrogen can really help. You don't need to carry a little pad everywhere, or worry that you might need a spare pair of knickers.
Right. So if people wanted to get in contact with you, how do they get in contact with you?
So right now I'm working the Cayman Islands. You'd probably have to come here. And we do see people who actually fly in from Canada and the US just to see me, whether it's for their vulva or something completely different. You can have a look on the website on Integra, and you can book directly an appointment on the website, or you can phone the reception desk or come in. Certainly via Integra at the moment. I used to work in the UK, but I gave up all my private practice and closed it down to come to sunny Cayman. So I no longer practice in the UK.
Okay.
But you said that you're on LinkedIn.
I'm on LinkedIn. Yep. So yeah,
you can look you up there. Yep.
But for anything medical, just get in touch with Integra and book in and just come and have a chat.
Okay.
And not be afraid.
Don't be afraid. And I don't even have to look at your vulva. We could just have a chat. You don't have to show me anything. Usually I have to have a look in order to diagnose you, because if I can't diagnose, then I can't treat correctly.
Right.
But ideally you come and we examine and we see what the problem is and we work together to fix it. But like I say, I would never force a treatment on anybody. I listen to my patients. There was a great physician a long time ago, William Osler, who said, listen to your patients. They're telling you the diagnosis. Yeah. And this is what I do. I take a very careful history. I sit and I listen to the patient in front of me, whether it is a genital skin problem, male or female. I do look after male genital skin problems as well. Whether it's a child or an adult, whether it's just a lump or bump or a rash, I take a very careful history. And most of the time I've worked out what's going on by the time you've told me your story. And that's usually the longest bit of the consultation. And then when we examine you just to confirm or refute what we're thinking. What is our differential diagnosis? So we usually have 1 or 2 top things, sometimes 3 in our heads, and then we examine and go, oh, it's this one, or it's very rare that you'll examine and go, oh, something completely different. Yeah. Most of the time you can work it out if you listen to your patients.
Awesome.
Right. This was a very good conversation.
It was.
Very
and
interesting.
hopefully we can continue it and dive into it a bit more. So thank you very much for coming on.
It's a pleasure.
Thank you.
It's really good. I want to spread the word.
Yes, definitely.
You did a great job.
I'm really glad you're doing this podcast. I think midlife is a time we struggle, as women especially. Our hormones changing. We're balancing, we're juggling children, sometimes partners, jobs, social lives, houses, elderly parents. Yeah. Exactly. There's a lot of stress. I suppose just the one thing I forgot to say is that some people come to me and they're convinced it's a perimenopause, but actually they don't have the symptoms to be in the perimenopause. They're perhaps menstruating every month. They haven't got the classical symptoms. And when I sit and talk to them, sometimes it's stress. We take a lot on. We don't look after ourselves. I find, especially as women, we're the primary caregiver in a lot of situations. And so we're so busy looking after everybody else, and we're right down at the bottom of the pile. Sometimes you just need to listen to your own body and think, okay, why is this symptom happening now? There's always a reason. Why now? And just to sort of not ignore those symptoms. Go and get them checked out. Work at your stress levels. Take time for yourself. Journal. Such a good way to let go of everything. There's so much evidence that journaling is so good for our mental health. Take time out, whatever relaxes you, whether it's yoga, whether it's a dog walk, whether in Cayman it's a beach day with your sunscreen. I am a dermatologist. But, whatever relaxes you, do more of it, because our hormones interplay, and our stress hormones like adrenaline and cortisol actually interplay with our female hormones. And so stress makes all these symptoms so much worse.
Right.
So we need to address that too. We can't just give you HRT and just go, you'll be fine. If you've got a stressful life, we need to look at that as well.
Yeah.
It's wonderful. Thank you.
You're welcome.
Thank you so much. Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!